would like to start by thanking Professor Shuham, Professor Milton Long, and all the organizing committee for taking us under their wings this year's World Congress for the IVF worldwide. I'm sure, like many of its previous years, you will enjoy it and you will enjoy the new scientific content that we have. It's my pleasure to discuss with you a very focused area of new ideas in stimulation for polycystic ovarian patients that are undergoing ART. Basically, we're not sure who are polycystic ovarian patients. Are these two ladies the classic PCOS patients with the central obesity, insulin resistance, or these young ladies that are running 10 miles a day? Are these the PCOS patients with a little bit of high LH and normal insulin and no insulin resistance? Give the polycystic ovarian syndrome patients. Basically, there are three issues with polycystic ovaries. There is the irregularity in the cycle and anovulation. There is the hirsutism, and then more recently is the incorporation of ultrasound in those patients. A few years ago, 30 years ago, the NIH made a consensus conference for discussing what's of PCOS, and they said that if a woman clinically have anovulation or amenorrhea or oligomenorrhea and hyperandrogenism, whether clinically or biochemically, in the absence of other etiologies like Cushing syndrome, like ovarian tumors, like pituitary tumors, like anything else pathologic, then this constitute PCOS patients. The reason they came up with this definition was very simple. They wanted the same definition to be applied to the docs that work as a family medicine doctor in the rural areas as much as the REI professors in the major institutes. So this does not depend on sophisticated testing, and it's almost like a widely inclusive diagnosis. About 20 years ago, both the ASRM and the ESHRI got together in Rotterdam and made this Rotterdam ESHRI ASRM consensus group that was published both at Fertility and Sterility as well as Human Reproduction simultaneously. And they said there are the three issues that we all are very familiar with. There is oligoanovulation, and there is the hyperandrogenism, as well as the ultrasound showing polycystic ovaries, which has been in Europe widely used in the 90s after the work of Professor Howard Jacobs and others, of course, the absence of other etiologies. So if you have those two out of the three, then you can say that the patients have polycystic ovaries. Many societies, like the Androgen Excess Society, disagree, say that polycystic ovaries have to have hyperandrogenism. All that being put aside, we're all very familiar with these two ultrasound pictures. That is one of my patients showing you many follicles that measure 2 to 9 millimeter, basically less than 10 millimeter, and you have to have even 12 or more in each ovary. Also, increased ovarian volume could be used in the diagnosis that was coined together by Dr. Balin, Levin, Tan, and Duweli, among other authors, for both human reproduction as well as the fertility and sterility issue. Of course, we're all very familiar today with the metabolic effects of polycystic ovaries, which was initially described 40 years ago today in Boston, where they reported it. And again, after Professor Howard Jacobs' work, I mean, this has been elucidated very clearly in the 1980s. Many of those patients have markers, skin markers, like this one of acanthosis nigricans in the neck of a hyperandrogenic, hyperinsulinemic patient with PCOS. But the major risk for those women is the visceral obesity. The visceral obesity is the contributor to their cardiac effects, as shown here by this tomogram by Professor Adam Balin in this nice photograph. The issue of insulin insensitivity is not related to weight, but is compounded by weight. So what is the issue of it? We look here at the insulin. The insulin first attaches to its receptor, and then a series of events happen after that, after the attachment of insulin. So some people with insulin resistance have, for example, an abnormality in the configuration of the receptor, or have an abnormality in the number of the receptor being decreased. This is not polycystic ovaries. In polycystic ovaries, the problem happens is post-receptor, and is beautifully demonstrated here from Dr. Case. Beautiful book on the management of ovarian disorders, showing you on two sides, the normal size on the left and the PCOS size on the right. So the normal side showing you a tyrosine phosphorylation following the attachment of the insulin in the pink to the insulin receptor in yellow, and this results in the cascade of events with normal metabolism. Whereas in polycystic ovarian syndrome patients, there is excess of free fatty acid, and there is an abnormality, as I mentioned, in the phosphorylation. So there is more serine phosphorylation here, resulting, as we see at the end, in an excess in the androgen production in those patients. The androgen production, it could be mildly elevated, but the amount of free androgens is significantly elevated in those patients, and hence the clinical features, whether the patient complains of it in terms of facial hirsutism, acne, the size of the hair lips, as well as many others. This is a very dear picture to me. This was our sonographer from London in 1986. I think this was actually one of her Lancet publication. That was how important it was before the development of transvaginal ultrasound as widely as it is today, and showing you the pearl necklace appearance on the ultrasound. But today you can easily see those, and among others that we all do, showing you here increased stroma, but the stroma is not part of the diagnosis, with a large number of follicles that we see there. That has an effect on the endometrium that is tremendous, because on the left side you see the beautiful trilaminar appearance of the endometrium in the normal follicular phase, whereas in the middle, if you do not make any progesterone, then you will eventually end up with hyperplasia, and even hopefully rarely in some patients, if untreated or uncorrected, then they could develop into cancer of the uterus itself as endometrial carcinoma. Today, we're discussing together just one area, which is the infertility, and one of those areas which is specifically stimulation in those high responders patients during ART. I will not discuss today many of those, very important, but not part of the that is related to ART. These are being well covered by our speakers in our Congress here today in different areas. A few years ago, I asked my friend Roy Homburg to summarize his wide experience over 4 decades in the management of these patients, and actually in our book, Human Assisted Reproductive Technology, and the second edition, he's also contributing to our ovarian stimulation. Basically, of course, the patients should lose weight, should have more exercise. If this doesn't work, then you can use either clomiphene citrate or aromatase inhibitors. Most of the time, we're using letrozole now more than clomid. I mean, we still use some, but when with high BMI, and of course, at the end, low-dose gonadotropins. Laparoscopic ovarian drilling is mentioned here not as a stimulation protocol in itself, but as a way to avoid ovarian hyperstimulation syndrome in women who have previously been hospitalized with severe HSS. As you will see from the new technologies, that this has become almost obsolete because of safer technologies, as I will discuss with you in a few minutes today. Lifestyle, I mean, there is no question that losing weight is very productive. Again, as shown here by Roy Homburg, loss of 5 to 10% of body weight is enough to restore reproductive function in almost half to all the patients within 6 months as well. Clomiphene citrate has been used for decades, and then I just want to say that most of those pregnancies happen in the first 3 cycles. So persisting after 6 cycles of ovulatory is will give a very low yield. That is at least my opinion on that issue. The problem with clomiphene citrate, as shown here by this work from Bob Casper from Canada, is showing you that the endometrium is disturbed, and the reason the endometrium is disturbed is subendometrial blood flow is disturbed. This is, again, from Bob Casper, the courtesy of Professor Graham Burton from Cambridge, showing you the impact of SERMs on the subendometrial blood flow, and hence the problems that we see with that. What are the other problems? From from Bob Casper's work with Yale Gone and his fellow this is going back 30 years ago, showing a thin endometrium in those group of patients as well in polycystic ovaries. Many trials have compared clomiphene alone versus metformin versus clomiphene and metformin. There is no question that clomiphene was better, and the addition of metformin was marginal, at least in these studies. Let me go through these because these will be well covered by our other presenters, the aromatase inhibitors and why they are good, and then finally the ovarian drilling, one of our most expensive ways to avoid OHSS, but we do not need it today. Let me tell you this afternoon that our focus in this patient is two things. Number one, success. Number two, safety. They have to go hand in hand. So the stimulation for ART has been radically changed by the development of the antagonist in the stimulation. And although we were one of the groups that were, shall I say, one of the earlier groups to adopt the agonist in the 80s, so we were very keen that it stays. But now the use of the antagonist has completely, if not almost completely, replaced the agonist in women who are high responders. And this is what allows us to use the GnRH agonist to trigger ovulation, because the antagonist allows the pituitary cells to still store the FSH and the LH, and hence when you give a GnRH bolus 36 hours before stimulation. From Abulgar and Al-Anani work a decade ago, they showed that if you do a meta-analysis, you will see a very much lower incidence of OHSS in these patients if you're triggering ovulation with an agonist in an antagonist cycles compared to, for example, if you use an HCG in an agonist protocol. The agonist trigger itself was introduced because the HCG was the prime stimulator of VEGF. There are 4 types of VEGF, A, B, C, and D, and there are 3 types of receptor, R1, R2, R3. When VEGF-A works on R2, you result in excessive stimulation, opening of the blood vessels, and leakage of fluid and capillaries, and hence all the features that we're all too familiar with, or hopefully we're too familiar with in the past. So it could be used only in antagonist cycle. You cannot give an agonist to release the thing if you've already been using an agonist throughout. The use of the agonist to trigger ovulation antagonist cycle resulted in a very, very, very much lower rate of OHSS, hopefully rare, unless you're adding an HCG to the stimulation. What are the doses that has been used for the agonist? For example, in leuprolide, anywhere from 1 milligram to 4 milligram. Many people have used 2 milligram 36 hours and 2 milligram 24 hours, and I'll come back to that. Many people have used 4 milligram ones 36 hours. We currently use 4 milligram ones 36 hours, but there is a good rationale for using a second dose 24 hours because they found that some of those patients would have a low yield of OSI, sometimes none, and because the LH and the progesterone would be low on the morning after the trigger shot. So if you check them and you find it's low, you can give it, or you can make it part of your own protocol to give it all the time. If there is any specific reason, you can do both. Like I said, you can give it 36 hours as well as 24 hours, and still will result in a much, much, much lower rate of OHSS. From JCM 20 years ago, again showing you on the left side is when HCG is given as the trigger, the luteal phase is very, very healthy in a way. When GnRH is given, this is what you see on the steroids, the progesterone, and the estradiol in the luteal phase. So that is the price that you pay if you use GnRH agonist trigger. Again, in the meta-analysis of Yusuf, showing you again the agonist trigger in 8 randomized controlled trials with fresh and 3 randomized controlled with donors. There was 0 out of 266 OHSS severe in fresh and 0 out of 171 in donor when the agonist was triggered. In contradiction, 6.8% say 7% develop OHSS when HCG was given. So what's the catch? The live birth rate is significantly lower because of its impact on the luteal phase. The impact on the luteal phase is significant. So the live birth rate is 0.44 with a range of 0.29 to 0.68. So basically half. So the next question that I'm proposing to you is this effect on the oocytes or on the luteal phase? There is only one study that looked at the effect on the oocyte by looking at the outcome when the embryos were frozen, when vitrified blastocysts, and then they were used in a separate cycle. And work from McGill University, from actually Michael Dehan, showing that the pregnancy rate was lower in GnRH cycles compared to HCG. These are pregnancy rates in subsequent frozen transfer cycle. I just have to tell you here to acknowledge that this was a retrospective control. So this was not a prospective randomized. All other studies that looked at it prospectively, they did not find a difference in the pregnancy rate, to my knowledge today. Again, from Bart Fauser, GCM, showing you the LH, the FSH, the estradiol, the estrogen and progesterone, when different triggers are used. And here I'm showing you HCG and triptorelin. And again, there is no question, it is confirming the same, that if you, if you use HCG, steroids in the luteal phase, unless you supplement with steroids tremendously. There is no difference on the like on the gametes themselves. So here is PCOS and non-PCOS patients, showing you basically the agonist trigger being used for both of them in a publication in Fertin Sturt 5-6 years ago today, and showing you similar number of oocytes, similar maturity, similar fertilization as well. Sometimes, however, you can get empty follicles. So this was always thought to be, well, it is those group of patients that actually do not have a good progesterone level, good LH levels on the morning after the trigger. But was abstract in the ASLM 14 years ago, looking at a big number of cycles, over 12,000 cycles, and looking at about over 100 cycles of empty follicle syndrome. They abandoned after they and repeated it 6 hours later, and they got a decent number of oocytes. David Meldrum summarized the agonist trigger, said that if you give the agonist trigger, you will decrease, there is no question about that, the OHSS rate. But you will have a lower pregnancy rate. So maybe a combination would help, and suggested a dose of 1,500 units of HCG given either at the time of triggering or sometimes even at the time of egg collection. An alternative would be to do a very high dose luteal phase support, although in our hands the pregnancy rate was still low, and hence we use usually a freeze-all in those patients and do a subsequent single blastocyst in a second cycle. Again, from Peter Homaidan here, looking at the work 10 years ago, showing the 300 cycles subjected to 10,000 HCG, or taking an agonist trigger plus 1,500, pregnancy rate was the same, delivery rate was the same, pregnancy loss was the same. So showing you that it's an alternative protocol you keep in your back pocket if you decide to do fresh transfer. Again, another European publication here, looking at if you give it 2 milligrams of leuprolide and then 1,500 units at the time of egg pickup, not at really the trigger time, and then they used vaginal quinone, they used oral estrase, 2 milligrams twice a day, basically 4 milligrams of estrogen, all the way till 8 weeks, and then you can see here that again the chance of OHSS was significantly reduced, like a 1% in this study. Bruce Shapiro analyzed his own data looking at 3 protocols. Number 1 is an agonist only. Number 2 is a dual trigger, meaning a agonist plus a low dose HCG. And a third group looking at agonists with an intensive luteal phase support. To summarize the work, when you use the agonist only and you do not use intensive luteal phase support, you had a low ongoing pregnancy rate, approximately 25% or 1 out of 4, and an early loss rate of 58% or 1 out of 2. Whereas when you use the dual trigger, as I mentioned, or you used the agonist with a very intensive luteal phase, you got a higher pregnancy rate, which is basically 58 and 50%, and a lower loss rate, which is 20%. We have looked at the recombinant LH, and at the beginning it wasn't possible because of the very high dose of recombinant LH that was used to trigger as an alternative to HCG. But today this is, I mean, and then we abandoned that like maybe 15, 20 years ago. This is coming back again as well. So, ladies and gentlemen, at this point, I would like to stop and summarize what I have been discussing. GnRH agonist following the antagonist seems to be the way forward to prevent OHSS in PCOS patients or patients that have high response depending on your group. You can use whichever classification you like, the Bologna classification, whatever. But if you think that your patient is going to be very high responder, very high levels of estrogen, for someone this could be 4,000, another person this is 5,000, we basically consider using an agonist only to trigger if the estradiol is above 2,000, 2,500. And again, we do freeze all in those patients, and we do a single blastocyst transfer in many of those. So I think the practice has changed. What we would have been doing with PCOS patients 10, 15 years ago is not what we're doing today. And this is at the level of the day-to-day, because again, we all want success to our patients, but we are very cautious about safety. And I think this approach gives us at least a window. It would be helpful too if the progesterone is elevated, if the patients want PGTA, or many other reasons. For any reason the patients is doing that. It would be our way going forward. There has been several other new approaches, perhaps that I'll just highlight in our second edition of this ovarian stimulation book. The Chinese groups have been using progesterone instead of the antagonist for the past decade, which is actually remarkable. Like, I mean, this has been used widely worldwide in the last 2 to 3 years, but they've been using it as a routine. And they have a database now that they shared with me during our last visit there before the COVID became restrictive. They had a database of almost 30,000 cycles with decent results that I think we could all look forward to hear about. I want to thank the organizing committee for giving me this wonderful opportunity to share some thoughts, and perhaps that would hopefully open some discussions for all clinicians involved. And best of luck.
Boutros, thank you very much for really an excellent presentation. I have just a very short few questions for you. Based on your experience, is there any upper limit for BMI while you decide not to treat the patients?
Well, really, this has been amazing. We both practiced in the UK, and now I practice in the US, and I think that the practice is radically different. In the UK, we insisted that the patients would lose weight before she is involved in our IVF program. In the US, unfortunately, all clinicians advise weight loss, exercise, maybe other measures as well, but eventually the patients seem to be the final decision maker, because tremendous number of patients fail to get a BMI that is even below 35, and with those patients we do them. There is no question to all of us that there is a negative effect. This is not even the discussion. I think practically what has changed it in the US is the significant increase in bariatric surgery in many of those patients. And I can give you examples of some of my patients that we failed to achieve even good blastocysts for them, and they got pregnant on their own after dropping their BMI from like 42 to 22.
And how do you choose the starting dose with those very obese patients, and what gonadotropin formulation do you use?
So the starting dose, we go up by 75 units in those group of patients. So if you want to say we classify the patients into, again, you can take any classification, but everyone has in his mind a group that are high responders, normal responders, and low responders. So say, for example, you go by AMH and you take less than 1.2 would be your low responders, 1.2 to 3.4 would be your normal responders, and then above 3.4 would be your high. So for the high responders, we basically use 150 units as a starting point. For the normal responders, 200 to 225. For the very low responders, we use 300 units. Say this is the patient that the BMI is 25, 26. Say a patient is really BMI 34, 35, then we add at least 75 units. We still typically start with FSH only for the first 5 days and then add, basically use HMG from day 5 to day 9 or 10, depending, and so forth. In some of those patients, we also use very low dose HCG as a supplement in the cycle.
Is there any limit to the number of eggs that you aspirated while you say, well, I will freeze all embryos and not replace? Do you have any upper limit to this?
We already have moved, I don't want to use the word radically, but we've moved radically towards a freeze all recently. I mean, that has been the case. So in the past, we used to say, well, 15 or more, less than 15, and so on. Now, even if somebody has 12 oocytes with use of freeze all, I mean, we feel also it gives us an opportunity to select better. So the freeze all would give you the opportunity to wash them to blastocyst stage, and then freeze them, and then be able to select a single blastocyst and so forth. So we have lowered our criteria to a significant point. There is, however, many patients, as we all have, that I mean, somebody in their 40s, they challenge us, and 2-3 times they've done IVF, we've never reached blastocyst. So for those, we do a day 3 transfer and day 5 transfer if we can. But we have lowered our ceiling, as you exactly say, for the number for doing a freeze all as the time went on.
Thank you very much. I think it was very interesting, and thank you for being with us today, giving such an interesting lecture.
Thank you. It's my delight. I wish you a very successful conference and many more years to come of success.
Thanks.
Thank you.